Welcome to Learning Thursdays. Learning Thursdays are offered to addiction professionals as a free learning opportunity with the goal of improving the knowledge and skills of the New York State substance use disorder workforce as we strive to improve the lives of individuals in prevention, treatment, and recovery services. And I'd like to welcome everybody to the final year of ethics. Today's topic is going to be problem solving and decision making in the clinical environment. My name is Trisha Allen. Some of you know me as T, and I'm here with my colleague Maria Passeri, and we will be talking to you today about this topic. I would also like to remind you that if you do have any questions, please feel free to send them to Learning Thursday at oasas.ny.gov. So the goals of the presentation today are to review the different models of decision making in the clinical treatment of substance use disorders, to define the shared decision model and identify the patient benefits of using this model for treatment planning, and then to understand how information, values, and preferences of the patient contribute to good patient decision making. And then to also explore motivational interviewing and how that impacts those with substance use disorder and shared decision making and how you can use those to positively affect patient outcomes. So some of the decision making skills in the substance use disorder population that we're going to talk about. Individuals who have SUD, they can show a lot of signs of impairment with decision-making skills. This is something that we frequently see with our clientele. They have a tendency to look to immediate reward, so they usually choose or can choose or make decisions that offer, that immediate gratification, and that can have potentially negative consequences for the patient. And there's also an emotional dysregulation that impacts their decision-making process and their decision-making ability. So what we're going to go a little bit deeper into is why do they do that? And I'm going to turn it over to Maria, who is going to speak more to that.
Thank you. So what I thought we would start with is a little bit of science. And this particular study I thought was very interesting, and it also complemented the work that we'll talk about later in the presentation. So we're going to take a look at the Somatic Marker Model of addiction and its relationship to the decision-making process. And when you think about your experience in dealing with our patients, this model makes sense. But there isn't a lot of research around the ability of our patients to be making decisions. So we're hoping that we can find more science that will support what we're doing and provide us mechanisms to do best practices with our patients. So the primary point of the Somatic Marker Model is the decision making is guided by emotions. And many years been in the field, we know that feelings are associated with, we often call the disease a feelings disease. And so this model kind of supports that. So the somatic states can be induced from two types of inducers. The first one being the primary inducer, or the innate or learned stimuli that induce pleasurable or adversive states. So for example, someone's first drug use can provide a pleasurable state. And therefore, that first moment where they contact with the drug is a good memory. It could be a gambling win. A gambling win is a very good feeling. But it also can be an adverse effect. So an adverse effect would be a gambling loss, which kind of hurts. The secondary inducers are the recall of a personal or hypothetical emotional event. So it's about the thoughts and memories of the primary inducer, which elicit a somatic response. And when we talk about somatic response, we're talking about the emotions. So I want to make sure that you understand everything that we're explaining in this particular model. And so you go from the drug use being something positive, and then having that memory set in their brain, and therefore continued use is around remembering that pleasurable event. So in the research, the Somatic Marker Framework attributes decision-making impairments to a defect in the emotional mechanism that rapidly signals the prospective consequences of an action. So when we talk about their emotional mechanisms, we're talking about it being defective, which is why sometimes as treatment providers, we don't understand why our clients are making these decisions. And if you talk to the general public, we want to say, why aren't they just stopping their use? So we have to remember that there's a defect in the emotional mechanism. And so they don't necessarily take a look at the consequences of their actions. The emotional mechanism is a somatic state which is relayed to the brain. And so that's where when we call it the disease of the brain and then the feelings disease, this is where those two things come together. So after the somatic stage is triggered by the primary inducer, which is the drug, okay, and experienced at least once, now there's a somatic pattern formed in the brain. So there's that pleasurable emotion which is associated with the drug.
So this would be a circumstance where they were, chasing that high, I think is what they refer to it, where they continue to use because they're trying to get to that original experience, that original positive experience. They're seeking to get that again.
Yes,
right?
That's very true. Okay. That's very true. And then the secondary inducers, which is your memory and your recall, are presumed to reactivate the pattern of this somatic state. So they're reacting that pleasurable feeling, which then the next use happens. And so, I felt that this is a very good research article that kind of supports then, the different models we're going to use when we help our patients make decisions in terms of the treatment plan and what their plan is for recovery in their life. So in conclusion, while this theoretical framework is still being evaluated, the model provides an account on how emotional states guide our decision-making process. And we know that as individuals who are not in treatment, we oftentimes will make decisions based on our emotions versus taking a look at the pros and cons of our decision-making process.
They go with their gut.
Yes.
Their intuition.
Yes.
Yes.
Yeah. Reversal of substance use alone is not sufficient for the improvement of decision making. So even when we take away the drug, and even for a period of time, that doesn't mean that individuals know how to make good decisions. And therefore, then sometimes we can't assume after they've had a period of abstinence that they're still going to make good decisions.
Actually, I heard a discussion about this recently, and it wasn't so much about decision making, but just about being, when you're in recovery. And I thought it was really enlightening. People were discussing, just going to the park or going dancing or, being around people in social situations and having to relearn the whole process because previously, when they had done it, they were in, to some degree an altered state and being in recovery, they were almost starting from scratch to relearn the entire process. So I found that really interesting.
And if if they were doing drugs in the park, then the recall and memory of the park can trigger the impulse to use.
Yeah.
So individuals really must relearn how to think and behave in a particular situation. And what we know today and what OASAS always emphasizes is pharmacological treatments in conjunction with cognitive and behavioral rehabilitation can improve the decision-making skills. So we need both. Medications support health as well as providing those evidence-based practices with cognitive behavioral rehabilitation. And what we will add at the end of this presentation is motivational interviewing.
So one of the things when we're talking about treating individuals with SUD is having effective decision-making skills, right? And how does that actually impact their ability to have a successful treatment experience and then a successful recovery? So when we're talking about this experience as practitioners, our goal is to provide high-quality SUD treatment services because that's the only way, that we're going to engage these individuals and we're going to get them onto this path and to continue on this path. And part of that is having a thoughtful treatment plan at the start of the treatment episode. So this is why a lot of times what you'll hear us say is that treatment begins the minute a patient, or the discharge plan starts the minute a patient walks in the door, right? You're supposed to look at everything that they need, plan out their treatment as soon as they walk in, and try and gauge what the goals are, what are the outcomes going to be, and how are we going to get them there. And the expectation is that that will happen in a very thoughtful and collaborative, really, process with the patient. The core of any treatment plan is the process to translate knowledge into decisions. As clinicians, we are the subject matter experts, and our patients are coming to us seeking guidance and seeking skills that they don't currently have. And our main goal, right, is to provide them with the instruction booklet, so to speak, or the ability to take that knowledge and to apply that to their lives and try to improve their decision-making skills in this particular circumstance. So there's a lot of different treatment planning models out there, and they all reflect differences in how you prioritize sources of information and how you integrate those. And then it also is based on which stakeholders are using that knowledge to make the decisions, and also the stakeholders' values. Are you weighing their values versus their needs, if they're particularly focused on medication-assisted treatment, and how much that's playing into the decision-making process when the decisions are being made. So I spoke about this a little bit earlier, but one of the central focuses of our patient rights regulations, it's in 814 of our patient rights regulations, and it says that each patient has the following right, which is one is to receive services that are responsive to individual needs in accordance with recovery, an individualized treatment and recovery plan, which the patient helps develop and periodically update. So again, the expectation is that the patient is going to be included in the decision-making process and is going to be working with the clinician to come up with their treatment plans, expectations, goals, and that there will be a continued modification of that as the patient progresses through treatment. Now with that, I'm going to turn it over to Maria, who's going to cover shared decision-making.
Okay, so it is really important that we provide shared decision-making when we're working with our patients. While we have the expertise in terms of how to make good decisions, we also need to understand that the patient really knows about themselves and that they are the best person to provide information about what they need, what their values are, what their preferences are. So the shared decision-making model is an interactive process through which clinicians and patients are collaboratively determining the course of treatment. And the benefit to that is that you see increased patient satisfaction. They also feel empowered and they have autonomy in taking ownership of their recovery plan. They also increase engagement in the treatment tasks, and we know that patients often, if they're going to leave treatment, they're going to leave early on in treatment, and so if they're not getting engaged because they feel like everything is being done for them or they're being told what to do, they oftentimes will bolt because it's not for them, and that's oftentimes what we hear when we pull patients around, why did you leave treatment? And it also facilitates the a more effective treatment plan. We want a treatment plan that doesn't look like everybody else's, that is particular to the patient's needs and wants. So patients prefer having an active role in their treatment, and report wanting more information about their disease, regardless of symptom severity or age. And there is a lot to understand about the disease of addiction. So I think that it's important for them to have a basis by which they can begin to understand what's going on for them. So the core tenets of this model are at least two people have to be engaged in the decision-making process. Shared implies meaning that the decision is mutual, and at times others may be involved. And again, I think that that's really important, that we don't necessarily take the time to take a look at what is the treatment team saying, because sometimes they offer a more broader perspective. The physician or psychiatrist at your program, and as well as family members. And we know when we're working with a younger population, families are involved in the care as long as the patient would like them to be. And it is important to hear what they have to say. Another tenet is that each person shares information. So there's a transfer of information that's bidirectional. The patient is in the best position to share information about his or her specific symptoms, preferences, values, and goals. And that's so important and oftentimes overlooked in the treatment planning process. The clinician has the expertise with the development of the treatment and the particular drug that the patient may be utilizing. And each person in the decision-making process must have at least a basic understanding of the other's perspective. So it's important, and if you feel really strongly that the house that the particular person is selected for aftercare is a house that's had numerous problems and incidents, it's important to have that dialogue that their relapse prevention plan would have to be extremely strong to be successful in an environment where there may be a lot of triggers. So it's that transfer of information that happens at this process. So decisions are made collaboratively, as I said, and decisions are made through a process of discussion, compromise, and agreement. So there's two types of decision-making theory. The first one is prescriptive, and that really helps us identify what good decision-making is and how to help individuals make good decisions. So we'll talk a little bit about that process and its prescriptive approach in terms of looking at pros and cons and having that time to discuss and collaborate. And the descriptive decision-making theory is how individuals and groups actually make decisions. So what is it that's happening that's helping them make the decisions? And I want to remind you with what we talked about earlier in this session is we have that emotional mechanism that's happening that we have to be mindful of during this process. So the prescriptive theory, let's get into a little bit of detail here. The framework proposes that the best decisions is the one in which the expected utility is maximized. So we want to clarify the likelihood of different outcomes for the patient and helping the patient identify the strength or different values to determine the expected outcome of each choice. So in the case of doing the treatment plan, choice might be what is the aftercare placement, what is the housing environment that the individual is looking for, and it could be what is the type of medication-assisted treatment the individual might be looking to select. And we know that there are different housing arrangements. We know that there are different medication-assisted treatments that all take a look at what's going to work for the patient, what's going to be something that will be with their values and their preferences. So what are some examples of how you would use the prescriptive decision making? Like I said, The medication-assisted treatment is a good one to kind of give you an overview example. We have methadone, which is something that an individual has to go every day in the beginning stages and get their medications. There is Suboxone, which has a little more autonomy to it because it's office-based and it's a prescription medication that the individual would be taking. And then we have the long-acting injectable naltrexone, which is one injection for a month. So in all of those instances, they require action from our patient. And so our patient really has to take a look at what's going to work for me. Am I going to be able to get to a methadone clinic every day? Or does the Suboxone provide too much flexibility and I'm not going to be able to follow through with it? And if that's the case, maybe the long-acting injectable naltrexone is something that would have the least intrusion in their day-to-day life. But it's their decision. And so it's helping them understand what is the information about the medication and how does it fit into the lifestyle of the patient. So that's the kind of discussion that you have with this. And then the second question we have is, do you see any issues with this approach? And I'm sure you're all saying, this takes a whole lot of time to do. And we have a problem with our regulations. We got to get that treatment plan out within 7 days if you're in an inpatient program. And so that kind of intensity of getting this work done in a short period of time is some of the reasons why we often take control. But then when we take control and make the treatment plan look like everyone else's, the consequence to that is, a higher ACA rate or leaving against clinical advice. And in those beginning stages of treatment, we're doing a lot of work at that time. All of our paperwork is front-loaded in the beginning. So if you have a high ACA rate, then you're doing a lot of work over and over and over again. So the ideal aspect is if we spend time with the patient, the patient then sees that their particular problem is a priority to you and that you're going to take the time to discuss that, you're less likely to have someone leave against clinical advice. The descriptive theory is maximizing the decision quality. However, it does not help the patient understand how decisions are made. So in the prescriptive side, we're talking about how the decision is made. Now we're going to be looking at the quality of the decision. The descriptive theory also helps the patient understand how the decision is made. Individuals either process information unconsciously, intuitively, consciously, and analytically. So the unconscious intuitively is oftentimes that emotional state. The conscious and analytical is much more the process that we'll talk about with the shared decision-making model along with motivational interviewing. So the likelihood of making personal decisions, patients often choose the first acceptable option rather than considering all options fully to understand the best option. And so that's back to the unconscious, intuitive, emotional state decisions. The components of the shared decision-making model, in order to make a truly collaborative decision, you must have adequate information. And as I kind of laid out the medication-assisted treatment model, you have to know each one of those medications in order to understand which one might be best for you. An understanding of the treatment-related values, what's important to the patient. That might be that the patient needs to get back to work. That person may feel that employment is very, very important and that they need to be working. And awareness of established preferences and what is it that they prefer to do, what works for them.
So continuing on with the shared decision-making model, what we're going to talk about now is one of three pieces of it. So the first is information. And I will say it sounds so easy, but it's actually quite complicated in the treatment setting or in normal everyday life, actually. So some of the things to think about when you're talking about information when you're working with a patient is what information do we provide? Maria touched on this earlier. When we're talking about the medication-assisted treatment, are we talking about the benefits of each medication? Are we talking about the level of participation required from the patient? Is it going to be a daily circumstance, a monthly walk or visit to the doctor, or is it going to be something somewhere in between? When we talk about objectivity, it is important that we give our patients a very fair understanding of what the consequences and the benefits of, for example, medication-assisted treatment, and being really clear about that information so that they can make an informed decision as they try and move through the process of recovery. The other question you have to look at is how much information do you provide, and what information is relevant to the decision-making process. There may be information that it might be too much. If we're talking through a bunch of different issues with a patient all at once, it could actually almost be an overload of information, and that could potentially impair their decision-making process. So I think part of it is knowing how to approach the patient well and how to work through the information with them at their pace so that they're fully informed but not completely overwhelmed by the process. So the last question that we should be asking is, will the patient understand the information? I think I know I'm guilty of this. I'm talking to someone and I'm talking in what is my normal, ordinary lingo, and their eyes are glazed over and they're not really listening because I'm not really saying anything to them that's really consumable or understandable. And I will admit I do the exact same thing if anybody talks to me about technology. Glaze. So it is really important that when we're talking to our patients, we're taking that information and we're making it consumable for them so that they can understand it and they can apply it. Otherwise, it's not very helpful for them. So the next thing we're going to talk about is values, and this is again a similar caveat that I'm going to add, which is recognizing the difference between the patient's values and the clinician's values, and ensuring that it's the patient's values that are taking precedence when they're making any types of decisions. So when we talk about values in treatment planning, that is a reflection of the importance one assigns to the different aspects of treatment. So if you're looking at whether or not it's the treatment approach or how you focus on the treatment approach, so individual sessions, does the individual want family involvement, to what extent do they want family involvement? It could be somebody who's very, very family focused, and family is a very core part of their life, as opposed to somebody else who maybe has found that family involvement is not as helpful. Values can be focused on treatment outcomes as well. So this is where we were talking about medication-assisted treatment versus maybe total abstinence is a goal that they would like to look at. If they are seeking to get custody back of their child, if they're looking for, again, a different family involvement situation, maybe they're looking to reintegrate into their family, or maybe change direction if their family is not as helpful. But in either circumstance, what we have to recognize is the importance of the clinician to assist the patient in finding out what their values are. What do they find to be the most important, so that they can contribute to the treatment plan in a way that's consistent with their unique perspectives. This is the central focus of the shared decision-making model, is ensuring that it is the patient's values that are coming through and are being addressed while we're doing the treatment planning. So then also there's preferences. And this is applying the patient's values to the available information and treatment options that will result in the patient's preferences. So if they prefer to do medication-assisted treatment, and that is one of their focuses, and you've given them all of the information, then that will be put into the treatment plan, and that's one of their preferences. That's how that will be implemented. A way to look at this is to research patients' treatment preferences, and when you do that, when you pull that out from them, when you get that feedback from them, it does have a positive impact on their treatment. We do know that patients do have preferences. There is a way to assess that, and that patient preferences may and can impact treatment participation and treatment outcomes. Obviously, if you have an individual who's invested in their treatment plan and feels like they have been it's been a collaborative process, and their thoughts and their feelings have been taken into account, because as we discussed before, the somatic response, it's very much emotion-based as well. They're going to be more interested in staying in treatment and engaging in recovery and continuing through recovery. So, the structure of the decision-making encounter, this is kind of the step-by-step process. So initially there's an exchange of information. So you have a diagnosis of the patient. You try and understand what the patient's situation is like. What is their housing situation? What is their job? What medications or what substances are they using? What are their values? What are their core beliefs? And how do we take that information and then we deliberate about the options? So this patient has identified to me that family is a very core part of their value system, and they do look forward to having their family involved, and they would like to pursue injectable naltrexone. So when you look at their values and the beliefs, then that's how you identify what your patient's preferences are. And then you talk with the patient, okay, this is what's going to be required if we decide to take this process or this step. We do medication-assisted treatment. You'll have to go once a month to the doctor. And then the clinician will make recommendations and then discuss those with the client and determine if that's what they want, and that becomes the treatment plan. So this is the finishing thought of the decision-making discussion for this part, and then I believe we go into motivational interviewing, correct? Mm-hmm. So learning information, and this is illness and treatment-specific information. The information is then interpreted through the lens of personal values, so seeking certain types of treatment successes, minimizing the likelihood of negative outcomes, and then as the patients make value-based judgments on the relevant information, they form preferences. In unilateral decision-making, these preferences are the primary drivers. And with that, I will turn it over to Maria.
Okay, thank you. If you take a look at this particular figure, this is the model of decision-making in clinical practice. So first of all, you take a look at initial preferences. What is the patient saying day one? And together, when we talk about the team, we talk about you and the patient talking together about what are they thinking about treatment, what are they hoping to gain, what are their goals. And so sometimes these initial preferences, again, are going back to that, the emotional mechanism, because right now they have not learned a whole lot. They just think they would like to, they prefer something versus having an informed decision. The next piece from that in this process is the option talk. So taking a look at what are the options. So if they are interested in family involvement, are there programs out there where they might be able to bring their children? If that's something that the patient values and has a preference for. So what are the options out there? And then taking a look at their initial preferences, adding on the options, and now coming to some sort of decision. So now we're having a decision talk. What is it that we might decide to do? And then ultimately, they're making the final decision, which is an informed preference, and pulling that all together, and now utilizing information and values and preferences together. Now, we have this a lot, that decisional conflict, and that results from uncertainty regarding the choices available to the patient, especially when the choices involve risk, side effects, or when the choice contains elements that are both desired or undesired. So in the case of selecting, let's say, the discharge plan of a residential program where there's a lot of structure, but less opportunity to kind of do what you want to do. And then there's the sober house where it's a lot more relaxed, there's a lot more autonomy, and as clinicians sometimes we're leery to send somebody to that level because we feel that their relapse prevention plan isn't that strong. We know the incidence of relapse. We also know the dangerous drugs are that we have today on the market that can take someone's life. And so the patient may be very focused on that sober house when you're trying to guide them to a residential program where they can get some structure, solidify the relapse prevention plan. And so there's this risk here. And so there's where the decision-making process in that previous model comes at an impasse. So when that happens sometimes, then the patient's upset. And the process, you may need to alter the process. You may need to take a look at what is it that the patient needs at this time. Maybe we want to find out where that anxiousness is about being in a structured program. And also we can take a look at what are some options that they might need to do sequentially instead of simultaneously. So maybe we talk about maybe a short-term program and then with the goal of getting to a sober home. So it's utilizing and understanding where the patient is at and coming up with some options that could make it progressive versus jumping into one or the other. And so this is where motivational interviewing comes in with the process, because we still want to meet the patient where they're at. If we ignore the fact that they are not ready or that they're resistant, we need to spend some time with that. So it's really important that we weave motivational interviewing and shared decision making together. So motivational interviewing and shared decision making provide practical and well-prescribed methods to accomplish the patient-centered care in the context of situations where medical evidence supports specific behavior changes and most appropriate action is dependent on the patient preferences. So, putting these together, the approach can be utilized to address ambivalence to medically indicated behavior change. So anytime there is that decisional conflict or the patient's not sure, not ready, this is a time where we begin to utilize our motivational interviewing skills. Support the patients in making healthcare decisions in cases where there's more than one reasonable option. So we need to take a look at where that patient's at. And we often utilize our interventions when we think that the patient is in the action stage, when in fact they're not. So assessing where they're at in the stage of change is really critical during this process. And if somebody is still ambivalent, we shouldn't be utilizing interventions that indicate that they're actively involved in recovery. The rationale for combining these approaches: the data from surveys and qualitative and observational research state that clinicians often do not take patients' perspective into account. Rather than clinicians promote or recommend specific treatments rather than consider the patient preferences during the decision-making process. And when we do that, the patient is less invested because it's our decision and not theirs. And a motivational interviewing approach enables the clinician to have a goal for counseling while acknowledging and exploring variations in the individual's commitment and interest to changing their behavior. So sometimes if we spend a little bit of time with them in addressing that ambivalence and or resistance, they see that we're also invested in helping them make good decisions. Motivational interviewing recognizes that making behavioral change is difficult and that telling or persuading people to change will often meet with resistance, and we know that. And even though we know that, we usually go down that road. And that's where supervision is helpful. That's where the multidisciplinary team process is helpful in providing feedback with our colleagues. Instead of viewing resistance as a problem or failure, motivational interviewing approaches resistance as ambivalence, and we should explore and resolve it. So I understand that you're not in agreement with this, and now we need to get to why you're feeling that way. And we don't want them to feel like we're critical of what they're doing because they're at a different process. They can't see it yet. And it's only when they can see it is when they can make that next step. There are 4 components of motivational interviewing. Engaging refers to the building or helpful working relationship. That's that therapeutic alliance, which we say is the core of the work that we do. We also need to focus, a process by which a specific direction about change is developed and maintained in the conversation and through the episode of care. If we're not focused, the patient isn't going to be focused. And so it's really important that we stay on track, and that's why that treatment plan is so important. Evoking involves eliciting the patient's own motivations for change. Their ideas and feelings are recognized, elicited, explored, and reinforced. And while we talk about the fact that emotions guide us, we have to understand that. We can't eliminate that. So I'm not saying that we eliminate emotions. We need to recognize that they're there. And we need to understand how they relate to the decision-making process. And then planning. Planning encompasses both developing commitment to change, formulating concrete plan of action. It is the conversation about the action eliciting the patient's own solutions and continuing to strengthen talk about change as the plan emerges. And remember, we always keep in the strength-based approach when dealing with our patients versus looking at their deficits. So here is the model of the motivational interviewing process. So you see at the base of all of our work is the therapeutic alliance. And then we need to be focused. And then we need to pay attention to feelings and thoughts about that process. And then we get to the final stage of planning. And that's commitment. So you see, we don't start with commitment. And oftentimes when we're utilizing the treatment plan, we've already made the assumption they're committed to treatment. When the plan is reflective of where they're at in the stage of change, that's then it is more acceptable to the patient. Okay, let's take a look at this model, because this model really shows how we're incorporating the shared decision-making model with the motivational interviewing model. And you'll look in the 2 big blocks, okay? We have our reasonable options that we're presenting to the patient, and there's possible risky behavior that the patient might be engaged in or thinking about that involves decision-making. If you look onto the left side of this model, you're seeing that there's the goal at the bottom, which we want to get to. And actually, we should probably take it from the top, and I apologize for that. We have the context, the information that we're getting. What is it that we need to do? Then we move down to deliberation, which is the presenting the options, looking at the information, and getting to the ultimate goal of the decision-making process. And there's at the bottom of this model, you see making a decision and therefore making some sort of behavioral change. So the principles involved in decision-making, one is building a relationship between you and the patient, respecting their autonomy, understanding that they have information, and also being curious and helping them understand and getting intrigued with the recovery process. There are skills that are involved in decision making. We know that. They have to listen, they have to ask questions, they have to think about what might happen if we made a certain decision. We need to know what their preferences are, and we need to affirm and respect their feelings. So you see that the shared decision-making model in that circle is the team talk, the option talk, decision talk, while in the same time we need to be engaging the patient in that process, focusing in on the option talk. We need to make sure we're asking about their feelings and therefore helping them plan in terms of the treatment planning process. So I really liked this model because I thought that this was really helpful to see it all on the same page as it's integrated to evidence-based practices. So, kind of just give you an overview. This, the first task of this patient-oriented or patient-centered part is to establish rapport and trust. And we also want to make sure that the practitioner and the patient have common understanding of the issues being addressed. And we also want to explore the ambivalence and about making change, and that we need to be listening to what the patient is saying and what's important about what they're saying. And we want to draw out their reasons for making or not making those changes. We also want to discuss commitment to change. Are you willing to make this change? What is it that you need to be able to do to make that change? The patient needs to consider whether or not he finds any possible options to be acceptable, and if so, given the best circumstances and priorities that are identified by the patient. The practitioner's use of shared decision-making helps compare options by discussing the pros and cons of the potential treatment and listening carefully to the concerns as the patient forms his preferences, informed by the new information that they got from you. Motivational interviewing would help the patient explore ambivalence to change, focus on the goal, and help him build confidence. And that's the piece that I think is really important, because we all know our patients are afraid. And sometimes when we see the anger, what we know behind that anger is fear. And helping them address the fear, and in addressing the fear, they gain wisdom. The gift of expressing fear is wisdom. And so with that then, achieving the goal, while the practitioner, which is really important, avoids blame and guilt. So we don't want to go into, when you picked that the last time, you relapsed, you did this, you did that. I mean, there is a way to talk about how that was negative from the patient's perspective, not from our perspective. So how was that situation for you? And asking them and eliciting their feelings in response to sometimes decisions that they have made that have not gone well in their life. So in summary, motivational interviewing and shared decision making can be applied sequentially, so that motivating patients to change is followed by decision making to help decide on a preferred approach. It's equally possible and in many cases desirable to integrate these methods as an ongoing process. Both motivational interviewing and shared decision making are patient-centered methods. As you see, the patient is an important piece in this process, and we have to, and it's also promoting an ethical imperative of respecting their autonomy, respecting them as a person for their outcomes that hopefully are successful in improving their life. So now this really concludes our year in ethics together.
Yeah, we're done.
Had a great year.
Yeah.
And it was really nice to hear from individuals out there. We will be providing our email for future reference, and you please feel free to contact us at any time for decisions. But I'm going to turn it over to Tricia, who's going to kind of give you an encapsulated view of the 12 months.
Thanks, Maria.
Yeah.
So just as an FYI, the references are included, and I'm just going to scroll through them really quickly. And this is just the information that we use to inform the discussion that we had with you today. And then I would also encourage you to, as Maria said, reach out to us. We are always available.
Yes, we are.
Our emails are Tricia Allen at oasis.ny.gov and Maria Passeri at oasis.ny.gov. You may also choose to submit a request for information or a question to the Learning Thursday email box, which I believe will be provided at the beginning of this session and also in just a minute. But just to kind of wrap up our discussion over the course of the year, a couple of high-level points that I'd like to leave you with. The first is going back to my Justice Center roots. Report, 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 because at the end of the day, the worst that can happen is you have a non-reportable incident. But if you are concerned that there is a situation or an occurrence that's happening that is a reportable incident, you should absolutely report it. The second item that I would say is clinical supervision. We cannot stress enough the importance of clinical supervision. This is a tough field, and it's even tougher right now with the current epidemic, and talking with your supervisor and working through concerns and issues that you have as you're going about your practice is crucial to maintaining your own health as much as it is with helping the patients. So we do encourage you to pursue as a supervisor or as a clinician, a very robust clinical supervision model within your practice. The other point that I would make is continued education is crucial. Be it with us here on Learning Thursdays, and I would urge you to check back often because we have new Learning Thursdays coming out all the time, not necessarily Maria and I, but the agency in general has many Learning Thursdays. But from any manner of sources. And we encourage you to have the discussions afterwards, because while her and I are speaking together, or the presenter is speaking to you on the Learning Thursday, there's a lot of merit to talking with your colleagues and talking through some of the principles that we've discussed and applying that to your own program. We recognize that we're doing it very broad-based because we know that we have so many different programs in our state. So we do encourage you to talk individually or amongst yourselves so that you can kind of have that micro level discussion. And then the last thing that I will say is self-care, especially nowadays with the epidemic that we're facing. This field is very tough, and being invested in our clients, it can be very difficult as we watch them go through the ups and the downs of this disease. So we do strongly encourage self-care. So with that, I'd like to thank you for joining us today. And if you've watched the other 11 of these, thank you for joining us all year. Be sure to reach out if you have any questions.
Thank you.
Thank you. So one final note that I will add is your feedback is appreciated. So please, after you finish this session, take the corresponding quiz on the test portal. Testers will be directed to complete a brief survey at the SurveyMonkey link. So please be sure to do that. And thank you for joining us.